Good morning. It's a pleasure to be here with so many people and also to follow Alessandro, that is one of my best friends ever in the field of gynecological endocrinology. I was thinking that we met 30 years ago in Crans-Montana 88 at Gynecological Endocrinology, so we need to celebrate. And actually, I learned from him how women are complex, and when we want to deal with the issue of treating sexual desire, we are really in trouble because, as you can see, sexuality and female sexual dysfunction may arise from many, many, many different factors. Sexuality, we know, is multifactorial. We have not only biology there, but it's very important intrapersonal and interpersonal aspects. So a dimension that is not so easy to treat with drug. Keep in mind as well that even biological factors are quite complicated. It's not only a question of hormones. We can focus a bit on that, of course, in our society. This is usual thing, but it has something to do with the body function in terms of neurovascular, neuromuscular response, with the brain function, neuroendocrine function, neurotransmitters, but also we have to keep in mind that we have genes that predispose us to behaviors, and we are learning very, very much about this. And so to put everything together is not really an easy task. This is a cartoon I produced, very simple cartoon, just to help you to understand how we have to deal with this issue in women. First of all, always to think that we have a response within the central nervous system, the neuroendocrine threshold, that regulate desire and mental arousal, so something happening within the brain, but it is as well important for facilitating the central neuroendocrine threshold, the genital threshold. So we have all the different stimuli, internal forces, we will see they are hormones, external incentives, let's say a candle dinner in Florence, a top roof at the Bayoni Hotel, a very nice bag, Louis Vuitton bag at the mall, if you do your bus with your lover. So there are many different aspects. They are influencing the way the brain and the genital, they respond during sexual intercourse. You motivate yourself for a huge number of reasons. All these factors, they are epigenetic factors, and they are also impinging on neuroendocrine circuitry and genital response. They are genetically determined. So at the very end, you have these biopsychosocial influences operating at different levels, central nervous system and the genitals. To make the story simpler, of course, the endocrine milieu is influencing everything within the central nervous system, at the genital, directly, acting on their own receptor, or even through a non-genomic mechanism, as you clearly know, attending always this meeting, we talk about very much, not only on action on nerves, muscles, and vessels in terms of receptor, but also non-genomic aspects. You vasodilate thanks to estrogen, testosterone, and so on, and you have a genital peripheral response. And of course, on this biological system, you have to take into account always, sorry, I always put this interpersonal determinants, because these are the factors that complicate our life when we want to study drug in sexual medicine, okay? You see what happened at the level of the central nervous system more closely. You have the box of the brain. In there, you have desire together with mental arousal, and also you have orgasm satisfaction. There is all those circuitries, they are under the control of sex steroids. We know that estrogen may behave as permitting factors. You are a woman, you are sexually oriented as a woman, you feel a woman in every single nuclei of your brain, cortical, limbic, and the hypothalamus. Think about sex is also for reproduction. So there is a stronger link between sex and the fluctuation of sex steroids. Indeed, we know that progesterone is modulating the sexual response in women, affect receptivity during your luteal phase or when you are on a combined hormonal contraception, maybe your physical response is blunted because progesterone is always there, progestogens or whatever it is. And then we know that testosterone is the initiating hormone in the brain that gives you the biological spontaneous drive, of what Freud called libido, something that comes from the inside. But hormones, they act on the balance of neurotransmitters. All the neurotransmitters are out there in the brain regulating the sexual response. Dopamine first, seeking behavior, going towards, and then serotonin, noradrenaline, GABA, anxiolytic activity, and many other neuropeptides and neuromodulators. So at the end of the day, sex hormones prime the brain to be selectively responsive to sexual incentive, creating a neurochemical state more likely inducing sexual response in women. And in genitals is exactly the same. We have learned a lot on the genitals from the urologist. There is not only the vagina is for gynecologists, there is also the ureteroclitoral complex, something that gives really vasocongestion, sensation. It's something that contributes to genital arousal. It's not only the vagina that is for the coitus, but the clitoral and ureteral complex, it's really for the female pleasure, for the orgasmic function, goes throughout this little structure. They work exactly like a little penis with the same molecule. Nitric oxide, vasointestinal peptide, neuropeptide Y, and prostaglandins, we know so well for male. They all are under the control of the balance of estrogen, testosterone, and progesterone, and they play a role in the peripheral sexual response. So again, sexual hormones exert a trophic effect. We have learned that from the model of vulvovaginal atrophy in postmenopausal women, but in fertile women, they also modulate the threshold of the tissue response to all those external internal stimuli affecting this neurochemical array. So it's very important when we study drugs that target the brain to take into account that what happened at the periphery is as well important. So we cannot treat only desire, but we have to consider other aspects of women's sexual response, and we need to exclude all those women. For example, they have peripheral sexual pain for many other reasons other than vulvovaginal atrophy or whatever it is. Why? Because pain or not being satisfied with your sexual genital response is a strong inhibitory factor for desire as well. So I just put all these concepts at the beginning of the talk to help you to understand the real complexity of studying drugs. The component of sexual desire, they have to take into account also other aspects. Not only the drive that is related to hormones, we have said, but also there is a drive that is related to age, to how you feel physically and mentally, in which stage of your life cycle you are. This is equally important. And so you should test a drug in different contexts. It's impossible, okay? You have to take into account motivation. Think about if you are at the beginning of a relationship, you would like to make love every day, 3 times in the morning and 2 times at the night. But when you have your husband since 30 years, I think about my husband. I know everything about him. Of course, I motivate myself out of love, out of other different reasons, okay? And I'm still fine, okay? So this is crucial as well. When we want to study the biological drive, keep in mind, we really need to go deep inside the feeling of a woman. And this is not so easy. The real sexologists, they know that it's extremely difficult to ask in the office, do you have erotic dreams? Do you have sexual daydreams? Do you have a spontaneous desire? Do you masturbate or something like that? Not so easy. But this is the only way to pick up the biological root of desire. You know that the issue of desire is an evolving field because we were based, all the research we have until now with drug, on this definition. The definition that was in the DSM-4, remember that dysfunction in sexuality are classified by a psychiatric manual. And this is something that stigmatized, that point out the fact that that is something that the brain, it's really important. And the definition of hypoactive sexual desire disorder is the following. I've lost interest in sex, but this is causing a significant distress in my life, meaning that if I'm perfectly fine with my low desire, according to the definition, I'm not entitled to take a treatment. Okay? But it's very difficult to address the issue of personal distress. There are many aspects that can help us to do that, but for sure, we have three major points. If you develop the disorder gradually or rapidly, maybe you can recognize a factor that is giving you that, whereas if you have low desire all over your life, meaning that is lifelong, it's something that has more to do with yourself and not with some situation that can be there. So to measure personal distress or interpersonal difficulties is quite complex. And also, it's not so easy to separate the desire from arousal. And this is the reason why in the new classification, the author and all the committee, they were there to do the guideline, they merge the two conditions, female hypoactive sexual desire disorder and female arousal disorder, because the brain is working as a whole. And also they put more strict criteria for distress. You really need to be distressed the majority of the time. You really need to have a dysfunction for very long to be entitled to take a drug. But you will agree that there is a huge number of women that will be out from this box, but they still feel and they suffer from low desire. They would like to do something little. And in here, I believe it comes natural compound to try to help women just to rebalance a bit their own life. We don't treat really female sexual dysfunction. That is quite complicated if we think about that. We don't have drug to treat that. We can imagine we can really treat with a natural strategy a so complicated disturbances. But low general desire can be treated. Because you see, if we think at the box of the brain, we have many excitatory signals and many inhibitory signals. So the same molecule I showed you in the cartoon before, and you recognize some of the molecules that also Alessandro showed you, because they are the same molecule that the brain uses to regulate reproductive function and sexuality as well. And what happens when I have low desire? There is an excess in the brain of inhibitory signals. So the opioidergic system is imbalanced. This system, the serotonergic system that you know is so complicated, we have so many receptors in there, some receptors are doing this and that, it's a too complicated story. But at the end of the day, what happens is that you have a significant excess of inhibitory signals. And these inhibitory signals give you the condition of hypoactive sexual desire disorder. When you are overstressed in the brain, when you feel fatigue, you may have this excess of inhibition. Indeed, when you look at the registry of women having hypoactive sexual desire disorder, this is a very nice study because distinguish between when you have the onset of hypoactive sexual desire disorder, and this is in premenopausal women, in which we believe the hormones are okay, it's not the model of VVA and postmenopause, because we want to get rid of the idea that women, they have pain in the genital, okay? So this is the reason why I'm showing you fertile women. And look how it's beautiful. They did a registry of this patient, and they tried to analyze when, for the first time, women report having hypoactive sexual desire disorder, and all the factors, they are maintaining factor of the condition. So they are comorbid. Look, number one, pregnancy and recent childbirth. We say, okay, it's because the woman, she has to do different things. Mother, she has to be mother, she has to be lover, but probably there is a rearrangement in the central nervous system in which you exchange priority, and maybe you have more inhibitory signal in your brain because you are devoted to the baby, to care the baby, to do other things. It's also a question of prolactin, oxytocin. We don't really know, but women report that after pregnancy this is happening. Dissatisfaction with physical appearance. How you can treat that? You have to be on diet because, the body change. This has also to do with pregnancy, the pregnancy experience, or with other aspects of your body image. Stress and fatigue. Women, they are under stressed. Women, they are overstressed. Everybody is working with women knows that we do too many things because we are not like them. I'm not like Alessandro. I'm fortunate enough not to be like him. And so on. You see other factors, they are maintaining, they are more drug, such as, for example, the pill or antidepressants. So we always have to do a very accurate history. But you see that also as a maintaining factor, top of the list is stress and fatigue. So if we fight stress and fatigue in women, we can really do some good in terms of sexual desire. Then we have all the other biological causes we know, and we have summarized, especially in postmenopausal women, and you know that when you remove androgen from the female body with the model of oophorectomy, you induce a significant amount of hypoactive sexual desire disorder. But you remember that androgen goes down with life, especially after 35, 40 years of age. A woman in that segment, and keep in mind it's the same segment in which you deliver a couple of babies and you enter in a new phase of your life, they have half of the androgen they had when they were 20. So androgens usually play a role for that, together with many other aspects. So if we want to screen and to try to include a patient in a study, we really need to make a proper diagnosis. And what we have to do, we have to screen our patient in order to understand what, if this hypoactive sexual desire disorder is really there, and if other factors are contributing to that. And you see that if you consider all the different potential aspects they contribute to hypoactive sexual desire disorder, you don't have so many patients left for clinical trial, because you recognize so many factors they may affect hypoactive sexual desire disorder. And this is another reason why probably if we help women with natural compound independently from this population of women that we want to put in a clinical trial to try to find an effective drug, probably we will do a lot of good in the real life of our women, because we will help them a little bit. It's important to do sexual counseling. We don't do enough. Why? Because there are many reasons. But the most important reason is the top of the list. Nothing can be done medically because we are working so much, and we will see, we will have some lecture in the meeting that will propose drugs on this topic, but we are still in our infancy. It's extremely difficult to have a drug approved, as I said. It's not only a question of barrier between the patient and the doctor, it's really that when you open the Pandora box, you would love to propose something to your patient, and it's not so easy. Of course, a clinician can provide care at various levels of this complicated model of sexual counseling. This is my dear friend Cheryl Kinsberg. She is one of the best psychologists in the world that was capable of producing instruments for general doctor, for people that try to do in the real life the counseling. And you see that you should follow different steps, but nobody has to become a sexologist to address sexual issue of women. You can treat at your level of comfort. You can try to propose something to your patient. And of course, when you don't know what to do, or you believe it's a complicated case, you send to the sexologist. But if you just say, it's not my field, we cannot discuss that, this is really something that closes the door, and the woman will never talk about her sexual dysfunction anymore. You see, as I said, recovering sex drive in women is still complicated. We really need to look at the literature, and we know that we had a drug that was approved in the United States, flibanserin, probably you have heard that. Now we have another drug that is studied, bremelanotide. It's in phase 3 study, but really this drug, they are promising, but it's extremely difficult, for example, to bring them on the European market due to the fact we conducted the study that the socio-cultural environment is very crucial to influence their ability. Other drugs, they are under investigation. They try to combine the psychoactive agent and testosterone, but they are still in their infancy, really, because it's complicated to design study. And when we look at the level of evidence, we have only these two compounds, flibanserin and bremelanotide, that is not even on the market. They may have a level of evidence 1. We have the testosterone therapy, but we have said already this morning and yesterday, and throughout this meeting we will say that a lot, that is off-label for women. We don't have real product for them. And so what we have left, psychosexual therapy. Very important, of course, but cannot be conclusive. So, in this very, very recent editorial that I wrote, I really underline the need of non-pharmacological strategies, or at least complementary medicine, nutraceutical, to try to help women to find solutions that may complement not only the pharmacological approach, but also the psycho-relational approach, so cognitive behavioral therapy. Because it's true, and we will all agree, that the lack of approved drug with a clear indication for FSD promotes sexual market of products we don't know nothing. So it's very important also for us to study natural strategies to fix sexual problem. Women, we know that like that. Of course, we cannot prescribe an expensive placebo, okay? But if we base our knowledge on the component of these supplements, and we know that these components, they can do some good to all these complicated mechanisms we have tried to summarize, we can find many substances that are suitable candidates to improve sexual function in women due to their prosexual properties. And this is the reason why when Alessandro proposed me to study or to do at least a pilot exploratory study with a product, a food supplement that contains ingredients that provide, it's a biologically plausible, that provide support for the libido of women because it maintains normal hormone level. You recognize molecules such as damiana, muirapuama, black courge, but we have zinc, so crucial for testosterone, for example. Overall, this cocktail of molecules we have heard from Alessandro, I will not go to that, levocetylcarnitine, but we have arginine. We know that arginine is a natural compound it's a nitric oxide donor, is extremely important for vasodilation and congestion. So a food supplement like that can be an alternative. And so we designed with Alessandro a very simple pilot study that include premenopausal women with some kind of female sexual dysfunction and also with hypoactive sexual DD. you see, we included very severe patient because the cutoff of the questionnaire is 26.5, and I will show you that the women, they come and they talk about that, we realize they are really severely impaired. And so this is another major point, that not so many women with little symptoms, they come. You see the sample was alpha on COC and alpha not, and more or less half of the sample, they were nulliparous. The age was between 26 and 50. So they were premenopausal, 41 plus 7 years, and the median score of the FSFI was really below the cutoff. We investigate not only sexual function, but we investigate also distress. That is important to understand if women, they have hyperactive sexual desire disorder with this scale, and then we measure anxiety and depression with the hospital anxiety and depression scale and the general well-being of women with the personal global well-being scale. And you see our preliminary results. You see that we observe women for 3 months. The follow-up is ongoing. We will recruit more patients, but I thought it was nice to show you these results. You see, women very severe. At 3 months, we did not observe any significant difference in terms of total score of FSFI, but we observe a significant difference in terms of distress. Probably women, they were able to cope better with this kind of symptoms. And this is important because, you know, it would be ridiculous to see a strong effect in women so much impaired in a so short little period of time. Because, you know, over 3 months, many things can happen. And this is one of the reasons why we really need to have longer follow-up. This effect was evident in both populations of women, the one taking COC and the one taking not taking COC. And it was interesting to observe a little tendency in the COC group to have a significant improvement in the total score. So we hope we can improve this population because, as you know, female sexual dysfunction related to COC are a very important major aspect in our clinical practice. It was interesting to observe, however, that when we analyzed the subdomain of the female sexual function index score, remember, is desire, arousal, lubrication, orgasm, satisfaction, and pain, we found some little improvement in orgasmic function, in the no-COC group, and interestingly enough to me, on lubrication in the COC group. So these data, to me and to Alessandro, are extremely promising, and we want to go on with this study and improve really, and maybe why not doing also a placebo. I hope Sigma will help us with that. But look how is interesting the last piece of information I want to share with you. A significant improvement at 3 months of general well-being, vitality, less fatigue, I feel happier in my life, and reduction of anxiety and depression. So maybe this effect on sexuality is mediated by feeling better. And ladies and gentlemen, I believe this is the crucial point. When we want to help our patient in their sex life, we really need to consider the well-being of the person. And we always have to think about that the woman as an individual human being. She has a lot of experience there. And so sexual attitudes and behavior are really unique to the human being, and you can do really a randomized, double-blind, placebo-controlled trial. You can, but it's much more difficult for sexual medicine. And we have always to think about that as doctor, we cannot solve everything because we need also other aspects, and I believe the factor more important, even more important than a nutraceutical, is love. That is a great food for sex. Thanks a lot for your attention.